Okay, well, hey, thank you everybody for joining us today. Michael Tiso is joining us to teach us about concussion management. Real briefly, Michael actually graduated from our residency program, our primary care training program, last year, a couple years previous. And actually, were you the first graduating class from the primary care program?
Yeah.
Yeah. So an absolutely excellent resident and an excellent attending. He actually splits his time between general internal medicine and a sports medicine department. So he specializes in concussion management. And you might have caught him on the radio a couple of times. I got to listen to him about 6 months ago. He had a interview on public radio. So we're glad to have him here. And I'm going to pass the mouse and keyboard over to him. Thank you.
All right. Thank you. Today, let's talk about how to recognize concussion, what it actually is, a lot of questions about when to obtain imaging, and how to treat concussion and prolong symptoms, and then when you can return to work or play. Concussion is just any blow to the head that results in an altered state of consciousness. It has to be represented by confusion. There may or may not be a level of unconsciousness, but by definition, if someone is knocked unconscious, that is by definition a concussion. There may be some level of amnesia, which is memory loss, either before or after the incident. So along the spectrum of brain injury, you have like severe TBI way at one end of the spectrum, and then mild TBI or concussion at the other end. Concussion sometimes is thought of as a subset of mild TBI, so in the more mild range. They occur frequently in kids, teenagers, most often from sports. From children, you're seeing falls resulting in concussion. Obviously, sports with contact like football, hockey, and lacrosse have higher incidences. And females, most often see concussions in soccer, and actually it's higher rate of soccer incidence than in football or hockey. Also, we see it in the workplace as well. So one study looked for about a 10-year period for non-fatal work-related TBIs, and the overall incidence was 4.3 per every 10,000 FTEs or full-time equivalent work hours. Most commonly in younger males, usually from contact with equipment or other objects. In older people, in the slightly older age group, it's usually from falls. So there's really three mechanisms for how you can get concussion. You either head is a moving object and comes to an abrupt stop, such as hitting your head on the ground. The head can be hit by a moving object, like something swinging in the air. Or you don't even need to hit anything, just a whiplash injury alone is enough to cause a concussion. So there are some symptoms that are observed and some that the patient reports. So observed, we see someone having difficulty recalling events either prior to or after a hit or a fall. Maybe see someone that looks like dazed or stunned. They're forgetting instructions either at work or during a game. Answering questions slowly. Again, any loss of consciousness. Or just mood or irritability. A lot of times the personality changes. Then there's those that are reported by the patient. A lot of times headache and pressure in the head is one of the most common things. They may have trouble focusing their eyes, have balance problems, sensitivity to light or noise, saying they're confused or not feeling right. They can be feeling nauseous as well. It's important to make a distinction though between headache and concussion. Just having a headache is not defined as concussion. So for a concussion to occur, you have to have a headache, but also a change in mental status. You can get a post-traumatic headache from a hit too, but if you don't have any of the other signs or symptoms, it's not considered a concussion. So what actually is happening when you sustain a concussion is the movement of the brain inside the skull that's causing the damage. So there is a small diffuse axonal injury and a cascade of metabolic changes after this. So this is the reason why a lot of people ask why helmets, what they do for concussion. They can't prevent a concussion because you can see that video not doing anything to stop that shaking of the brain inside the skull. This is a slide from an animal model out of UCLA. Main point is it's just showing that after concussion there are cellular changes that do occur within minutes, but some actually do last for hours and days. And one of the things that some research focuses on is cerebral blood flow, which is thought to be one of the things that may be abnormal in people who are having prolonged recovery. So if you happen to be at an event, this is probably more rare. If you're at the site of an injury, you're at your kid's game and you see someone you suspect of having a concussion, the best thing to do is just remove them from the game. Checking on them every 5 to 10 minutes to see how they're doing is important. And then after that, a period of physical and cognitive rest. More often, though, you'll be seeing patients coming to you in the clinic setting, and I use this concussion assessment tool frequently. This is kind of like the PHQ-9 for concussions. It rates all the different symptoms from headache to irritability and concentration from a 0 to 6 score. And you score it in two ways, the total score, so adding up, like if you have 6s down the board, you multiply by the number of symptoms, and then just the number of symptoms as well. So on exam, first thing I notice when someone comes in the room is their overall demeanor, whether they're slumped over, look tired. Sometimes they'll be wearing sunglasses in the office due to the overhead lights. I always get vitals, supine and standing, at least on the first visit, because orthostatic hypotension is actually a result of concussion as well. And I focus a lot on the eyes, which we'll get into a little bit more, but nystagmus tracking and accommodation convergence, as well as the neck, because a lot of symptoms of cervical whiplash or cervical strain can overlap with concussion, and then a balanced exam. So one thing I've initially tested is smooth pursuits. So in this video, you can see you wave your finger back and forth in front of someone's eyes, probably about 6 to 10 inches in front of them. You don't want to go too far to the side, so usually about 30 degrees back and forth. If you go too far horizontally, then you will trigger nystagmus. So it should be nice and smooth back and forth, like in this picture. As compared to someone with an abnormal exam, where you can see here, the staccatic motion of the eyes can be very subtle at times, but the jumpiness of the eyes is abnormal. And as I'm doing this, I'm asking the patient if they're having any symptoms as well. Sometimes they have trouble tracking a finger. In children, this can be normal in a small percentage of school-age children, but if they are having the jumpiness, they shouldn't be having symptoms, the one distinction. Convergence is testing the ability of the eyes to focus on an object as it comes closer. So with someone with keep both eyes open and slowly move a finger or use this tool, you're asking them, when does your vision turn double? And it's abnormal if that distance is greater than 6 to 8 centimeters from the tip of the nose. Now, accommodation is with one eye open, one eye closed. You do each eye individually. And you ask them, when does the object turn blurry instead of double? So this is abnormal if it's greater than 12 centimeters from the tip of the nose. So these tests I focus on a lot because vestibulo-ocular dysfunction is a big difficulty after concussion. So again, symptoms can be blurred or double vision, dizziness, or difficulty focusing. And then the exam, which we just went through, the convergence, smooth pursuits, and then vestibulo-ocular reflex is when you hold a finger in front of someone's nose about 10 inches and ask them to focus on the object while turning their head back and forth, like they're shaking their head no. That if you have a patient with these findings on exam or symptoms, they'll have a prolonged recovery from concussion. The balance exam is usually only useful in the first 3 days. Romberg, you can have them feet together, arms crossed or out, eyes closed, and shake their head. This is the best exam, which is used for concussion, having them stand on their non-dominant kicking foot, one leg bent, hands on their hips, and eyes closed for 15 seconds. And then the tandem gait is like having someone walk on a tightrope in one line. Usually after 3 days, though, these are not reliable tests. One big question is when to obtain imaging. You can't see a concussion. Imaging is usually used to rule out more serious injuries such as a brain bleed or a skull fracture. 99% of the time it's not necessary. So when to get it, though, in adults, the best criteria that we have is the Canadian head CT rules. So it takes sometimes on an exam you have to have pretty big injury. I've never seen any of this, such as these signs of skull fracture, battle sign. These are usually more severe injuries. However, you have to be careful though in older people. So actually 2 or more episodes of vomiting is one more common thing. Anyone 65 years or older should be getting a CT of their head if they fall. And it doesn't take much of a fall. I mean, you're talking about 3 feet or 5 stairs, and that can happen in daily life. The other thing that I'd like to point out is the presence of oral anticoagulant loose. So we see a lot of that in our patient population, and if you're concerned, they should be getting CTs. This is taken from a lecture from an ER physician about his opinion on when to refer to the ER. So declining mental status over time, that's why it's important to serially check someone at maybe every 10 minutes for at least the first couple hours. Any seizure-like activity, cranial nerve abnormality, which is going to be less likely, again, signs of skull fracture, persistent GCS of less than 15, or any obvious spatial deformity. For a normal concussion, initial treatment should be rest, both mental and physical activity. This is important to tell patients. It includes phones, computers, anything with a screen. May need some time off from school and limitations on their homework, which we call accommodations, and talk more about the sub-threshold activity. There's really no standard guidelines of when to return someone to work or school, but we're trying to keep each patient below the symptom threshold. So if someone's able to do work for 30 minutes but then gets a headache, I would tell them to try and do work for 20 minutes, take a break, and keep doing that frequently throughout the day. One study in the journal Pediatrics in 2015 took school-age kids 11 to 22 who presented to the ED, and they separated them in 2 groups, one strict rest of 5 days compared to the usual prescribed care of like 1 to 2 days of rest. Actually, the longer rest group did worse. So while kids may need to cut 1 to 2 days off of school or adults off of work, keeping someone home for days to weeks at a time is not beneficial. And physical activity, so we don't progress to physical activity until someone has fully recovered from, as far as a mental activity standpoint. They can't have any symptoms at rest or with work or school before getting back into activity. And there's no set protocol, but consensus statement from 2012 has put a graduated return to play as the standard of care, going from approximately 6 days from no activity to light aerobic exercise, and finally return to full gameplay. But it's not easy to, so if you have a swimmer, it's more difficult to do this. You don't have contact games, you don't have non-contact drills, so there is, it's up to some interpretation. Everyone in Ohio who's been removed from a high school athletic event, either suspected of or who has been diagnosed with concussion, has to see a physician to be cleared to play. So this is a form that has to be filled out by the physician before they can go back to athletics, and you have to say that they either have to do the return to play protocol, they don't have to with a reason why, or sometimes if they didn't get officially diagnosed with concussion, they still need this form to bring back to their school. Most concussions, average recovery is 7 to 10 days. However, there's a subset of patients, about 10 to 15%, who, for whatever reason, take longer than this. People who are prone to this are history of migraines or other anxiety or depression, previous history of concussions, female sex and increasing age predisposes this, as well as the mechanism. So symptoms can overlap, of post-concussion syndrome can overlap with other diagnoses, which just makes this difficult to diagnose, such as anxiety or depression. There's been multiple definitions for this, kind of vague, which is what makes it also difficult to diagnose and treat. There's also, you have to be, unfortunately, aware of secondary gain issues with prolonged symptoms. So in 2004, a study reviewed 120 studies and found that in people who have prolonged symptoms, one of the only factors that was found consistent was litigation or monetary gain. So that's something to keep in the back of your mind with someone who is having recurrent or continued symptoms. But there are many people who do, for whatever reason, not recover in the normal time frame, and I try and break it down to 5 areas of focus when I'm treating them. First one, and one of the most common complaints, is headaches. So there's really no guidelines for the treatment of post-traumatic headaches. What I'm trying to do is identify the type, whether it's migraines or tension or coming from the cervical region, and then trying to treat the underlying cause. First line, after the first initial few days of concussion, so now we're talking again prolonged recovery, would be NSAIDs. So 1 to 2 weeks of an NSAID can help, but after that, no more than 3 days per week, or you risk a medication rebound headaches. If it does seem like a migraine headache, triptans can be used, or prophylactic if it's more than 4 times per month. Most of the time, though, I'm trying to focus on other factors, such as if someone's not sleeping well, if they're having dysfunction with their eyes, neck involvement, and at times, too, we'll refer to there is a new headache clinic here at OSU, and they actually get patients in within the first 1 to 2 weeks now, so that's a good resource to use. We also have cognitive rehab available here, which is through the speech department. They're focusing on treating memory impairment and concentration difficulties after concussion, and they're really just going through memory and concentration techniques, such as writing down notes. It's pretty simple things that can help patients in the months following when they're having these difficulties, and sometimes they just need reassurance that symptoms will likely improve. In the prolonged period now, again, exercise can help. So low aerobic exercise can actually help and improve symptoms. Treating underlying anxiety and depression, whether that's with medications or with psychology or psychiatry help. And sleep is an important thing, which often gets overlooked. So if someone's not sleeping well, they'll not recover. So just getting into a good sleep hygiene techniques, trying not to use sleep aids. My first thing would be to try melatonin, and instead of an hour before bed, I'm telling people you should take it around dinner time so it works more effectively. And then vestibulo-ocular treatment. We have both vestibular therapy and occupational therapy, which will focus on balance and ocular rehab. So trying to refocus the eyes if you find something on physical exam that is abnormal. We'll talk about the specific referrals too. So often, again, the neck can be overlapping with concussion symptoms, so cervical therapy can help. This is through the physical therapy department. Treating the neck, as far as if there's a neck just simple strain, can show improvement with headaches and other symptoms. Usually once you are able to get a hold of one symptom out of the remaining symptoms, then you see like a domino effect and everything starts to get better. So this is a little bit confusing, and it took me like 6 months, I feel like, to figure all this out when I first got here. So on exam, if you have primary ocular findings, you should refer to occupational therapy. So they're going to do the vision rehab, and it's located on Morehouse, 2nd floor. If it's a vestibular issue, if they're abnormal Romberg or tandem gait, then that's a vestibular rehab, also on the 2nd floor. They do work together here, so if you refer to the wrong one, a lot of times they'll say, hey, do you mind putting in this other referral? So but that's the difference between the two. Again, neck pain then is referral to regular physical therapy, so that would be just the regular physical therapy referral in IHIS through the sports department. The speech referral, if you're having trouble with memory or concentration techniques. And then anxiety and depression, I know a lot of times psych is hard to get into, but if you do have an athlete, there is sports psychology available, and they can get in within a couple weeks as well. Okay. So I think it's about 20 minutes, and I'll open up to any questions.
Great. You know, it's funny, a lot of it sounds like it's pediatric focused in the sense of it's young folks with athletic injuries, but you do see adults in motor vehicle accidents and falls. I don't know, for myself, I've always felt uncomfortable in giving patients advice, and the thing that really jumps out to me is kind of knowing all the resources. Now there's a concussion clinic at the medical center, isn't there? Could you tell us about that?
There's a couple of different ones. So the one through sports medicine, which is one I work at, if you try and schedule a motor vehicle accident, they won't let you. So they're keeping it just sports injuries, which I think the vast majority of what we see in internal medicine is not that. If you do have, there is concussion or the TBI clinic through neurology and PM&R, also at Morehouse. They'll see more complicated ones. If you have someone who is having prolonged recovery, like it's months, they've had a car accident, they had a work-related accident, they can be seen there. I can also see them here as an acute visit. I've seen a few patients like that as well. So there are resources, and then using the rehab referrals can help.
Okay, but a lot of what you provide is how to talk to people in that first early period, or how to give them a sense of what to expect and kind of that initial advice, because that's the time period when they need to be resting and knowing when to go back to work and when to go back to school, that's going to be before any specialist sees them.
One other thing that we see a lot too is that someone will think they're better, go back to work, and then they're working their high-stress job, even any job, 40 hours a week can be too much, and then their symptoms start to come back again. So really they weren't fully recovered to begin with, and then going back to work has exacerbated those symptoms. So that's when you're going to have to be working with them to decrease their work hours, give them certain accommodations and treatment strategies where they're not overwhelmed at work. Because if you're continuing to make your symptoms worse by doing too much, that's when you're prolonging your recovery.
Okay. Well, we can open up to other questions. Anybody on the phone? I just unmuted everybody's phone. Does anybody want to pose a question or share additional information?
Mike, in youth sports now, I don't know how long they've had this, but they have like a pre-performance testing where you can pay money to have someone test your child before they get injured, and then if they do get injured, then they compare it to I don't know, to see what the severity of the concussion is. I think it's more in your contact sports. Do you see any utility in that, or do you think that's just, a gimmick?
Yeah, we are testing a lot of those. So all the Columbus City schools for contact sports will test their kids. I think and the Old Sanjay schools are doing this as well. There are a few different proprietary neuropsychologic testing. One of the ones you may have heard of, Impact, is used here in Columbus a lot. Mm-hmm. The idea is to get a baseline of their cognitive function, doing tests like reaction time, verbal and spatial memory and awareness, and then trying to compare that to following a concussion. So you do see differences, and there's some evidence to back that up. Mm-hmm. It's not the end of everything, so I don't use it. I just use it more of as one tool in the toolbox, like physical exam, symptoms. They have the impact test, and that may be useful. It's more hard to interpret if you just have an after-injury event, because then you don't have a baseline. Other things that can throw that off, ADHD or even anxiety, can throw off those results too. Which is why if you do it, it's better to have the baseline test.
Okay. Other questions? Anybody on the phone have any questions? Is this a pretty common thing to see in the med-peds practices? So, because I don't think a lot of, as far as internal medicine training, I don't know that really comes up in our training much at all. It must come up a lot more in the pediatric experience.
Mm-hmm. Yeah.
Are you
the old people who fall too?
Yeah.
Yeah. I see a lot of people with trampolines in their backyards.
Yeah.
That's bad.
And I told my children, and I've made them very unpopular. I've told them that they are not allowed to get on the trampolines no matter what if they're visiting a friend's house. Do you think that's, do you have any thoughts about trampolines?
Yeah, not just concussions, but other musculoskeletal injuries is most common seen on trampolines when there's more than one person on the trampoline. So probably 9 times out of 10 when someone comes in with some kind of pediatric fracture from a trampoline, it's because there are 2 kids on there, and usually it's a smaller kid who gets the brunt of it because they get thrown off the trampoline and
they're going to be the second person to the bigger one.
Yeah. But it is a liability too if you have one. Having 4 kids on there and someone gets hurt, and if it's at your house, you're probably liable for that.
Get a good umbrella policy.
Yeah.
All right. Well, hey, I think it was a great talk. Obviously, a talk that a lot of us probably don't get a whole lot of training in. I feel better equipped on how to at least advise my patients early on. I feel better about what resources are available. It's nice to know they're right here at the Morehouse Clinic. What I am going to ask you to do, if you would, at some point, give us like one summary page that might have like the referral pieces specifically and some of that testing. If we could post that on the website, that way I think as people get calls or have patients come in about this, they have a quick resource to know how to use OSU's resources appropriately.
I can send out the symptom score sheet as well if that helps.
Yeah, oh, that would be great too. Yeah. All right. Well, thank you, everybody. We'll send surveys out here shortly, and we'll see you next week.